Welcome, and thank you for joining us for our live virtual MDA Engage DMD Symposium. While we would have loved to have been in person for this event, we appreciate all of you joining us virtually today. My name is Nicole Petrowski, and I am the Community Education Specialist with MDA. We're so glad to have you join us today for this important educational symposium. MDA is committed to community education, and we believe in the power of bringing our community together for opportunities to learn from specialists and having opportunities to connect with others. This event is part of our larger MDA Engage series with disease-specific symposia, community education seminars, and community webinars as well. Our community education seminars are geared towards general neuromuscular disease topics, such as best practices in care, research, and genetics. While each event will feature regional specialists covering those mentioned topics, each event will also feature a specialty topic, which you can view on the screen. I recommend joining these seminars as each one will have a different information shared that may be well suited for your particular situation. So to view the agendas for these seminars and to register, please visit the MDA Engage section under Family Seminars on mda.org. We wouldn't be able to put on our educational programs without the support of our generous sponsors. I would like to thank FibroGen, PTC Therapeutics, and Sarepta Therapeutics for supporting this DMD program. I would also like to thank the representatives who are in attendance today. Following the event, you'll receive an email that will provide some additional education materials from MDA and our supporters, so be on the lookout from that email, which will come from MDA Engage. Now I have just a few housekeeping items to go over before we begin our symposium today. We are recording today's event, and we will be posting it to the mda.org website for on-demand viewing in a few weeks to ensure that those who weren't able to join us live today are able to access this information. For those of you joining the event live, please know all phone lines have been muted. We also will be having a Q&A session at the end of each presentation, so please utilize the Q&A icon to type in your questions. If you hover over the bottom of your screen, you will see a tray of webinar icons. Click on the Q&A icon to open the feature and enter your question to host. You don't need to wait until the presentation is over before submitting questions. As questions come up during the presentation, please feel free to send those in. We also encourage participants to communicate with other attendees by utilizing the chat feature throughout the day. If you want to just say hi and let participants know where you are from, you want to share a bit of your story with others, or would like to obtain suggestions from the community, please use that chat feature. Simply click on that chat icon at the bottom of your screen and click to all panelists and attendees. That's important because you want to make sure you're clicking to the attendees so everyone can see your comments and suggestions. Feel free to use this throughout the day to connect with others. You'll notice too that we have a very full agenda. There are some small breaks between speakers, so please feel free to stay connected to the live broadcast during these times, but this will also allow you time to grab some water or a bite to eat throughout the day. This is also the time where we will be checking audio for the next presenter, so just know you will hear us checking that. Finally, we will be sending out a brief survey at the end of the symposium, and we would like to receive your feedback on what you heard today. We want to make sure we're discussing topics that are of interest to you, and we use your feedback to improve for future educational events. So thank you in advance for taking 5 to 10 minutes to complete that survey. With that, I would like to begin our day and present some information on what MDA is about and what we do for our neuromuscular community. We are committed to transforming the lives of people affected by muscular dystrophy, ALS, and related neuromuscular diseases. We are able to honor this commitment by our work in 2 areas: through innovation in care via our 150 care centers, resources, education, and recreational programs, and also innovation in science with a focus on research, therapies, and technology. We have been doing this work for 70 years. MDA is an umbrella organization supporting over 43 diseases in the neuromuscular disease space. No other nonprofit supports so many neuromuscular diseases. As an umbrella organization, we have the benefit of leverage key learnings from one disease to inform others. To learn more about the 43 diseases under the MDA umbrella, please visit mda.org under the About Neuromuscular Disease heading. The MDA has made significant investment in advancing the treatments for neuromuscular disease through our commitment to innovations in science. MDA is the largest source of funding for neuromuscular disease research outside the federal government, $1.4 billion since our inception. MDA's research is directly linked to approved life-changing therapies across multiple neuromuscular diseases. We developed the first and only data hub to aggregate healthcare, genetic, and patient-reported data and help accelerate future breakthroughs. MDA has been on the forefront of research in neuromuscular disease since our inception about 70 years ago. We are at a time of unprecedented change in the neuromuscular disease space with more treatments in development than ever before and rapid growth in the understanding of the mechanism of neuromuscular disease and its treatment. As you can see, we currently have 44 active DMD, BMD grants, and we have committed more than $221 million in DMD and BMD research since 1950. In the last 5 years, MDA spent more than $19 million on DMD grants. On this slide, you can see the progress that has happened in drug discovery over the past 5 years in the neuromuscular space. Treatments are now available for periodic paralysis, DMD, SMA, ALS, myasthenia gravis, and LEMS. MDA is proud to have provided funding to many of these treatments along the development process. Also, PTC Therapeutics has had a hand in developing Risdiplam as a treatment for SMA. Risdiplam has been a collaboration with one of our supporters, PTC Therapeutics, Genentech, and their parent company, Roche, and the SMA Foundation. So definitely exciting times on the therapeutic side, and it's definitely evolving. Next, MDA's Mover Data Hub. It's our neuromuscular observational research. It is improving the ability of researchers and healthcare providers to enhance the care and management of individuals living with neuromuscular disease and to aid in the development of clinical trials for promising new treatments. This is done by driving disease understanding, accelerating therapeutic development, and optimizing health outcomes. Mover collects clinical, genetic, and patient-reported data for multiple diseases to improve health outcomes and accelerate drug development. DMD is one of the 7 diseases included in the Mover Data Hub, along with ALS, BMD, limb-girdle, FSHD, Pompe, and SMA. There are currently 31 care centers across the country participating in Mover, with 60 more working on steps towards participation. Since Mover is an observational registry, data is able to be collected via telemedicine and phone visits with your neurologist, which is especially important during the pandemic, where patient care has shifted intensely to help continue work towards our Mover goals. If you have questions about participating with a care center or with the Mover Data Hub, you can email mdamover@mdausa.org or visit the Mover section on mda.org. Now let's look at MDA's innovation in care, and we will start with our care center network. MDA has the largest network of care centers for neuromuscular disease, providing best-in-class comprehension care. Our care centers ensure a multidisciplinary approach for patient care, which provides patients the opportunity to see multiple clinicians in one visit, allowing for comprehensive coordinated care and helping to reduce the number of trips required to the doctor. The MDA's care network is made up of over 150 care centers at medical institutions. We have over 2,000 providers working with families at these care centers, and we have over 12,000 individuals that are participating in clinical trials. You don't have to navigate your neuromuscular disease journey alone. We're here to help. The MDA Resource Center is available to provide one-on-one support via phone or email for individuals and families looking for information about the diseases covered under our MDA umbrella. Our Resource Center is staffed by caring professionals. Some are living with neuromuscular disease and offer a unique perspective to support MDA's community. So if you aren't currently visiting one of our MDA care centers and would like to, please reach out to our Resource Center for assistance. The Resource Center provides information, as I said, on the care center network, disease information, advocacy efforts, as well as our community programs and educational events like these. The MDA Resource staff are available Monday through Friday, 9 a.m. to 5 Central Time, and are typically able to answer all questions within 1 to 2 business days. One of our upcoming community events is our Muscle Walk. Families and their involvement in supporting MDA has been critical since the foundation of our organization, which was founded by families. Each year, families come together to support and be part of the MDA Muscle Walk, and this year will be no different. We have converted the Muscle Walk program to a virtual program, allowing you and your families to come together on Saturday, September 5th, to celebrate the work MDA does, and also celebrate the work and involvements of all of you, our neuromuscular families, their loved ones, and our supporters in raising funds and awareness for the mission of MDA. How will it work? Well, you'll register online and start fundraising by sharing with your network. MDA staff are here to help you get registered and with any questions you may have to start your fundraising. September 5th, we will be offering live moments that participants can join that will include a walk, a run, fitness class, and a celebration ceremony at 3 p.m. Eastern Time. The URL to join will be sent via the chat window, and we look forward to having you join us on September 5th. Another great tool that is available at your fingertips is the MDA Clinical Trial Finder tool. This tool provides a comprehensive list of current enrolled clinical trials in the neuromuscular disease space. The tool will walk you through some simple questions to direct you to the appropriate trials that meet criteria that you shared. You can locate this tool at mda.org/clinicaltrials. Also, MDA has a myriad of patient and caregiver resources, which are available on mda.org and through contacting the Resource Center. These resources include Quest Magazine, which is mailed quarterly, multiple print and online resources, such as the Caregiver's Guide, Teacher's Guides, and disease-specific information. Also, be sure to stay connected with MDA's blog titled Strongly. Now, I am pleased to turn the presentation over to our keynote presenter, Dr. Brenda Wong. Dr. Wong was trained in pediatrics in Singapore and the United Kingdom prior to her completion of the Pediatric Neurology Fellowship at the Cincinnati Children's Hospital Medical Center. Dr. Wong now specializes in the clinical care of patients and families with Duchenne and Becker muscular dystrophy. She founded the Interdisciplinary Neuromuscular Care Center at Cincinnati Children's Hospital Medical Center in 2000, and this provided optimal integrated care for patients with neuromuscular disorders, most of whom had Duchenne muscular dystrophy. She then transitioned to the University of Massachusetts in 2018 to focus on the UMass DMD program. The UMass DMD program delivers comprehensive team-based, collaborated, patient and family-centered care for patients and families with Duchenne and Becker. This also includes the provision of clinical trial opportunities for patients with DMD. So Dr. Wong, thank you for being here today. You can go ahead and share your screen and present your material.
Thank you, Nicole. Let me get this up. Good morning, everyone. Thank you so much, Nicole and the MDA, for inviting me to share on this topic of care for patients with Duchenne muscular dystrophy, and in particular, discussing the need and the case for integrated care. We are glad to be part of the MDA network, and we are only 2 years old, but we are MDA Care Center, and we're really, really pleased to be part of this whole community. Just a minute. Okay, just as we have advanced in the world of research, I'm so glad to see that over the last 20 years, we have pretty much made advances in the area of care for patients with Duchenne and Becker muscular dystrophy and their families as well. And I have seen since the year 1999, 2000, when we first started the MDA clinic at Cincinnati, how we've grown from a single specialty clinic to one that is multidisciplinary. And I think the next level of care, which I think as we advance through this journey, it's really reaching out for integrated care in a interdisciplinary manner. For multidisciplinary clinics, I think, we started off with having our colleagues in different specialties coming in together to see a group of patients, but without the support of a care team in terms of admin support, nursing support, and social work and all, it was hard to have services coordinated or integrated. And so I think the ultimate really is to really look at integrated care or coordinated care. And I think coordination of care really, it's to the fact that we collaborate and we come together with meetings and communications to develop an individualized care plan for the patient and for the family. So what really makes the such specialty care for Duchenne successful? I think I would just share these two elements that is defined by the NCQA, National Committee for Quality Assurance, where they have established a medical home concept for specialty practice as well, the patient-centered specialty practice, which is PCSP, and the standards that they hold us to really is to aim for the patient-centeredness in the way we manage our patients. Quality of the clinician-patient relationship is important for that journey that we walk through many years with the family and the patient. And more importantly, the ability to track the progress or to track improvements or stability or deterioration in function in order to inform care decisions. And I think with this day and age, with the IT systems, with EHRs, that has made it feasible with kind of overcoming the problems that we have always encountered with the very fractured and fragmented nature of not only the US health system, but everywhere, as well as specialists become more common in the management of disorders like Duchenne's. So that was more in terms of the specialists, but we mustn't forget that the patient PCP, primary care practitioner, pediatrician, or your internist really is also key to this integrated care concept of working together with a specialist. And I think it's difficult when patients say we don't have a PCP and rely on the specialist. There's always that need to have the patient go to the PCP for routine pediatric or internal medicine issues and accessibility at their doorstep, and for the specialist to provide the lens through the Duchenne lens, as I said, in terms of care needs. So it's been a pleasure for us to really work closely with PCPs that's very vested in taking care of patients with chronic disorders, to be able to meet the needs of the patient locally, and also to work with the specialists towards effecting some of the testing and getting back to us. So really that really entails information sharing, and I think again that is feasible through EHRs. I know as much as we hate EHRs, it was stressful, but over the years it has proven to be the tool that facilitates the effective delivery of care for optimal patient outcomes. And we used to say it's a technology of the future, using virtual meetings, but the COVID pandemic has really expedited this process. And I know, in fact, the database and Facebook group of PCPs, if there is what we think will be the future to work with a specialist, that really is key. And I think this really, we're very familiar with this from 2009, the standard of care guidelines for Duchenne muscular dystrophy, that really puts the patient and the family at the center, and also the PCP. But then you have all the various needs of the patient where they see various specialists and you see very little connection. But since 2009, I'm so glad to see that we have really moved forward with care coordination services that's available to ensure that the patient gets the services they need either locally or through networks across the country, and the ability to actually provide care for some of the patients with various complex needs through the concept of a care manager and in the nursing world. And I think that that really has helped specific families and patients who have more needs than others. And that leads us to the concept of a medical home. We are familiar with a medical home in the primary care setting, but this concept of a medical home in the specialty care setting, where most folks may not be familiar, but a patient-centered specialty practice started like way back in 2013. We had that going for my center at Cincinnati Children's at that time to get us recognized. And this really, I think, is closing the loop to provide the care that is needed through the Duchenne lens, but at the same time too, kind of connecting the dots for the families as they walk through this journey. So basically the concept of this is the medical neighborhood that, you know, it used to be like the primary care that will kind of reach out to all the specialists. But if you only have like one Duchenne patient in that practice or 5 in a primary care setting, it's very hard to really assess the needs of the patient through the Duchenne lens for various aspects of care problems. We'll go into that a little bit later. But so this is a concept of a patient-centered medical home in terms of the specialist that is going to be the one that connect the dots with primary care, the PCP, and the hospitals with various hospitalization, testing that's needed from the Duchenne perspective, and the follow-up visits, the school, and the other services. So there's always this whole network that we're talking about. But at this point in time, I think we're limited by funding for a team that's able to be providing that integrated practice unit. So it's starting that hopefully over the years, as payers see that with such a setup, you're going to improve outcome, not only for the patient, but for the population of Duchenne as well. So with that introduction as to what integrated care and the ultimate of a medical home with these specialists in terms of the clinics, we'll just kind of have walked through the background of what we see as the case for need for integrated care. And hopefully that can kind of like walk us through which are the problems that, you know, you think that you need to contact your specialists, and which are those that, you know, you would have to contact the PCP first. And as we all know, patients with Duchenne muscular dystrophy, especially children when you're first diagnosed, we look at them as a group with special healthcare needs. And we pretty much know it is the most severe form of childhood muscular dystrophy, and with no interventions and no treatment, the natural history has been as defined in books, the loss of walking between age 6 and 12, and morbidity in cardiac and pulmonary function, problems in the teen years with survival that's really in the 20s. And it's not uncommon, it's 1 in 3,500 boys. So we are mindful of the progression, and you can see that a lot of the problems in the initial years will be in the pediatric world with growth, development, and motor, right? And so you see a lot of the specialists, the neuromuscular doc, or the orthopedist or rehab person, and the PT. But over the teen years, you can see that we're kind of like evolving into the OT, the needs for assistive technology, and also the involvement of our cardiac and pulmonary colleagues at this time up to this stage. So the needs evolve, the needs change, and it really also involves transition stages from the pediatric age group to the adult, for which will be covered later by Dr. Platt. So as of this time, we have treatments that's available as opposed to many years ago when we do not have any. And I think the advent of glucocorticosteroids as standard of care in the early 2004, 2005, it's now been 15 years, and we have seen improved outcomes. But at the same time, it brings about the need to add on additional colleagues in the field of endocrinology to help us optimize the management of side effects of steroids to improve the benefit risk profile and improve that ratio of favoring the use of steroids. As what Nicole had mentioned, with all the developments in the drug approval process, we now have seen atulurin in Europe for nonsense patients with nonsense mutations. We have seen the approval of eteplirsen for skipping exon 51 for about 17% of our Duchenne patients, and of recently the exon 53 skipping drug for about 8% of patients as well. And there are more new emerging therapeutics in the pipeline, as we all are aware of, that would enhance the dystrophin production or a substitute protein with gene therapy trials and so on. And also there are ongoing clinical trials to improve agents to improve muscle repair, and also stabilization of the membrane and secondary damage. And so you can see that we are now facing the possibility of new therapeutics, and hence it is also more important to really optimize your function, that you are at the optimal level of function to benefit most from new therapeutics and not be held back by your contractures or your other problems that can be managed on a day-to-day basis that really limit the maximal benefit from new drugs. So I think, yeah, if you would look at what we have right now for steroids, basically that's what we have, but we still encounter a lot of steroid phobia because folks are not familiar with the side effects, and with inadequate information, we have seen parents make decision to not go for standard of care treatment. So we see steroids side effects a lot in the pediatric age group, with the height suppression, the growth, with bone osteoporosis, with the weight gain, with increased appetite, and truncal obesity and facial fullness. We don't encounter blood pressure problems that much in the kids. We don't see the edema that we see in the adults. We don't see the peptic ulcer and the other disturbances as we've seen patients over the last 2 decades of steroids. That's not been an issue. But, and this concern about increased infection, I know in this era or in this time of COVID, that's been a concern, but that really at the doses that we use haven't been a problem. And eyes, more the cataracts, and being a little bit more hairy is not a problem for the boys. And the emotional disturbances, in my experience, really it's the patient itself. We have addressed really the OCD nature and the outbursts first before you start steroids, and that has not been too much of an issue. So I think, with this, you now see the need that you need various doctors. So all in all, if you count the muscle system, the psychologists and the psychiatrists or behavior and all, the heart, the endocrine, the GI, because they do get constipation, the pulmonary, the renal and all, and pubertal delays. If you do not have a group or a team of multidisciplinary or interdisciplinary, you're going to see 8 specialists and all over the place, and they're not going to be connecting with one another. Even in the multidisciplinary setting, I find it really quite difficult unless there is a main a quarterback or a coordinator to integrate the care and walk you through and connect the dots for all the problems. So I think we really would then tease out into what are the areas, because of the various system involvement, the main areas that we want to think about, the patient with DMD and not the disease itself. So what I do is I lump them and divide them into categories so that will kind of direct you into which of the specialists that will be taking care of each function and which are those that your pediatrician can help monitor and work the specialist. So of course, for the motor function and dysfunction, we talk about clinical trials, new drugs, but really I think you must remember that you can actually improve your outcome just by remembering the basics, right? Like you need to make sure that besides the steroids, besides the new drugs to improve the strength, you really want to take care of your diet. We are what we eat, and we do not want to be walking around or just lumbering around with extra pounds. That's going to slow us down. And also the metabolic side effects that may affect muscle as well. And alignment is really the stretching. You know, folks don't stretch, but then the kids grow and then you get contractures and you lose function because of contractures. So this is one group that comes together with this aspect of care that is so important for the first phase of Duchenne, because we just want our boys to keep on walking longer. And of course, this growth, development, and nutrition is more pertinent because of the use of steroids. But you must also remember, without steroids, you actually grow normally, and that's going to ding you for your contractions, and you're going to grow normally, and that's going to ding you because if you look at the amount of muscle you have divided by the height squared, is going to be less, and that just by physics is going to affect that amount of muscle you have in your system per meter squared, and you don't do as well. Cardiac and pulmonary function, we know very well. The endocrine function, we've talked about that we need to monitor for, but it's so nice to see that we are so fearful of this, that we are on the look, but there's never been a big problem if you're compliant and not missing your doses and working with your doctors. But that's one thing that's always forgotten is that, you know, we know constipation is common in the kids and it's common in Duchenne's, but really it's undiagnosed, and a lot of times the symptoms are not flagged as constipation and that's missed. Urinary problems has a lot to do with constipation as well, and that I think the PCP can kind of help with those. The renal stones, it's really quite common in the older patients, but now more so in the younger ones as well because of the tremendous amount of supplements that some of these kids take and they don't drink enough water. And I think here the psychosocial function is key for quality of life. We must not neglect this aspect as well in our management of patients. And then not to forget, we manage the whole family, the carrier moms, they need to be in good health, and the carrier sisters and the grandmas and so on. And so here you see this is what is needed to manage the whole family in a holistic manner. And so as we go into each system, as we mentioned about in detail the motor function, you'll see that this group is going to be like primarily your pediatric neurologists, your physiatrists, your orthopedics, your dietitians, and the authorities for the equipment. And I think this team usually should work together. We should be talking to our rehab colleagues, we should be talking to the PT who evaluates the patient, and we call it the braceman, and then the orthopedic surgeons, because whether or not we proceed to surgery for scoliosis or heel cord release, a lot depends on the state of function of the boys, and it's so neat to be able to work together to come up with is this kid going to benefit from surgery or is going to make the patients worse? So this is one good example of, that small subgroup. And then we keep forgetting that the heart and lungs are connected, and it's nice to kind of remind patients that the heart, pumps blood to the lungs. And so if you feel good, even though you need BiPAP and you says you don't want to use a BiPAP, a nice reminder that it's going to ultimately affect your heart. It really is helpful. So we have our cardiac colleagues, reminding the patients that, hey, if you use your BiPAP, your heart's function can be helped as well. And we forget that the heart also pumps blood to the kidneys. And so our older patients now, we are mindful of the need as we treat the cardiac medications to not let that drop the blood pressure too much. And also to remind the patients to be well hydrated, not to be dehydrated. For then you will actually affect, like your blood pressures, if they're low, you're going to affect perfusion of the brain, the kidneys, the gut. But, right now, I think this is a silent sufferer, I would think. The fact that, we forget about the kidneys, and then the fact that nobody looks out for the kidney function until you get into kidney dysfunction, or you get dehydrated and you get admitted and they go into acute kidney insufficiency. So the heart, the lungs, and the kidneys, you can lump them together. And then we know that the endocrine problems are a lot resulting from the steroids, but when managed well, we have been able to avoid excessive weight gain and the insulin resistance with the weight problem that will ultimately head towards type 2 diabetes in the long term. And we want to avoid that. We want to avoid obesity. We want to make sure there's enough testosterone for muscle growth in the teen years. And we want to make sure that the bone health is optimized. We work with endocrinologists, but it's also an area where you can actually have the neurologists kind of screen and then send them to endocrine. You cannot afford to send all 300 of my patients to the endocrine clinic. They will not be able to cope for just surveillance. So I think here we have to work together with his colleagues, but really it's a screening process that can be done in all clinics. And we did mention, and we found that constipation is really common, and a lot of my patients, they will deny being constipated, but until they come to us with, wet in bed and stuff. So this two goes together until, they get to the ED. And so I think this is pretty under-recognized. And I think for me, looking forward as to what we would worry about for GI, it's really our obesity problems in our steroid patients or non-steroid patients with this epidemic of obesity in the general population is fatty liver and the risk of fatty liver in patients. So we really are mindful of making sure that we are in good shape should there be like new drugs on the market and not be dealing with liver dysfunction as well in the future. This is common. You can see that about a quarter of our patients have got problems that present, and that's why if you don't pick this up and you start kids on steroids, you're going to encounter all your steroid, you said is steroid side effects on behavior. But in my experience over 20 years, if you can fix this before you start steroids, we have not really gotten into problems with behavior side effects of steroids. So we work closely with psychologists, psychiatrists, social workers, school teachers, a lot of care coordination with phone calls, long distance and all, to just make sure that all these are addressed to improve learning, to improve, quality of life at home as well. And some families would not want steroids because of the behavior outbursts, but this is important to fix. And I think as a neurologist, we can easily address that. Care for the bones. I think we are mindful of the fractures that occur in 40% long bone fractures of patients before the era of steroids. And steroids actually, if you look at the numbers, also, the number of patients with fractures or lower extremities is also 40%. But steroids do cause fractures of the cancellous bone, which is here, this, this is the flat bones. So we need to monitor that, right, by giving them the surveillance of bone health in terms of monitoring their bone density, their steroids, and vitamin D, and then monitoring for the need for bone health medications to prevent the progression of osteoporosis. And that ties in with the side effects of this group of drugs in the dentist. So I've been on phone calls with a lot of dentists and dental colleagues as well. So this is one area whereby most of the patients who've got steroid phobia, I would say, is because they're very worried that, oh, I don't want fractures. But in our experience, I think these long bone fractures are not over and above in terms of that 40% for those without steroids. And so you walk longer as well. So this is also an area where sometimes it may deter patients, and they said they have cataracts and that they don't want steroids. But cataracts, as you can see, 100% by age, by 20 years of age, and you can see that 20 years of use of steroids and 50% by 6 years. But cataract surgeries are commonly done. It's easy, it fixes your vision, and so I don't think eye doctors should really be decreasing steroids and stopping steroids because the benefit over the risk of that, overwhelmingly is in favor of steroids. And so always talk to your neurologist, neuromuscular docs first before the eye doctors ask you to stop the steroids, and we need to talk to them. And of course, like some of the steroid, very rarely they get like, idiopathic raised pressure, and then we may have to work with the ophthalmologist as well. So the families, I think you'll get the genetic counseling session by Kim later. But here you can see that, with Duchenne or Becker's patient, the carrier mom, the carrier grandma. So in our clinic here at UMass, we felt like we need to take care of the whole family. And so we do see the moms and the grandmas and make sure that if they're positive, we ensure that, skeletal health is usually good. Only one grandma has got some, mild pelvic girdle weakness at age 63. But then the cardiac, you'll find that like almost, you'll find about a quarter of patients with scarring in the heart that may benefit from an anti-fibrotic drug. And then you can have about like 20% or so with decreased function that may need more cardiac medications. So that, I think, in summary, sums up what all that integrated care is involved. And to just finish off the talk, I would just remind ourselves the goals in us providing care for patients and families is I would like to adopt Dr. Rosenbaum, who works with the WHO's for definition of what is health, optimal health in children with neurodisability, of which like a chronic condition like Duchenne's is one. And he in his talks and lectures, you can see the F words, and you see you want to think in terms of fitness. And I think the fitness, really, we are very much the care team that is team-based, that is going to ensure that we provide all that care. And then the function, so that they can function well with the coordinated care that will enable them to function in spite of disabilities. And we also need to make sure that the patients are not isolated. They enjoy friends, and then they have their family to support them. They should have fun, and of course the future. And that's where you're going to hear the next talk about all the advances in all the trials that's to come. And so all in all, we provide in our team, as I said, collaborative integrated care that is team-based, that is coordinated and integrated, collaborative, and communication is key to success. And then continuity of care over the care cycle, and that will be covered by the transitions, where you would have the adult provider knowing exactly what the patient's previous history and trajectories are in order to make informed care decisions to continue that care in the adult clinic. And also, last but not least, care centers are all involved in clinical trials to help bring the new therapeutics to the patients to improve outcomes. So I think with this, I thank you all and for this time, and I'm opening this up for Q&A session.
Thank you very much, Dr. Wong. We did get a few questions, that came in. Let me get to the top. When you talked about the fractured healthcare system, is there a universal health document that allows all medical care facilities to communicate specialized information about patients?
I think really the family signs that consent for us to share their information. Now, with the system that we use, Epic, it is really awesome because Epic has been used by a lot of centers. So even though we see patients from various facilities, like the orthodox is somewhere else, but if that system, the doctors are all in Epic, it facilitates that sharing of information because there is a care everywhere, and each they come to clinic, they would have signed consent that we're able to kind of like pull in all the data, all the labs. So it's really cool. I mean, like, I right now, I mean, I'm able to see my patients' information and all in various clinics for those who have been at Cincinnati with me, and here I'm able to see their results from 2000, 2008, 2009. You see, the electronic health record system is awesome to facilitate that.
Okay. Here's a question for you. For families with multiple DMD sons, how do we tackle the difficult questions regarding seroconversion? My younger one could participate in gene therapy trial, but could pass antibodies to my older son. And as a result, my older one would get viral vector-based gene therapy.
I think we don't know at this stage, although in terms of who has antibodies, it would have to be done just at the point pre-screening because we're always exposed to AAV or these viruses. So I think that you can actually look at that in terms of the viral shedding. What is happening is that you give the infusion of the AAV vector, it peaks, and then by like a week, the levels come down, and really by a month, that comes really down to very, very low levels. So I'm not sure if that's a real kind of problem. It could be technically. So I know some families may have, the kid with the viral vector infusion, maybe stay at another place for like a month. So I think basically all gene therapy trials, we unless you're like local, but then most times they travel and they're usually at site for a month or so. And so by the time they get back, your viral shedding is down to lower levels.
Okay. This is a very specific question. Pfizer uses AAV9, whereas Sarepta uses AAVrh74. My sons were both tested for antibodies for AAV9 and they were negative. Is there a commercially available test for AAVrh74? If my sons don't have, he continues and says, if my sons don't have AB for AAV9, how would that correlate to AB?
For AAV viral vectors 9, Rh74, 8, there's no commercial test. That's what we're struggling with.
Okay.
And so I think you may be negative now, but you still have to screen and take the one just prior to, when the trial starts or treatment. Because you never know whether you'll pick it up in the interim period. Now, Rh74, AAV9, that there's talk that they may not get positively if they have, they're supposed to be cross-reactive at some, but then my understanding is that it may not be. So you just have to see which vector each trial is using.
Okay. In February of 2019, Dr. Gray talked in President Series lectures at UTSW about ways to tackle the issue of antibodies. Has there been any more research on this that would enable redosing of the current gene therapies via AAV9?
I think that there are strategies, and I think there's always like the ability to really have immune suppression right from the get-go. And get that antibody kind of addressed. But I would kind of leave it to experts in that area. From what I understand, there's ongoing work to address that.
Okay. What is the best, and I'm sorry if I don't pronounce this correct, bisphosphonate medicine, zoledrondic or panamondric acid?
Okay, so bisphosphonates for osteoporosis.
Okay.
I think, you know, there is the guideline, the care guideline that recommends IV zoledronate for moderate to severe compression fractures of the spine. But I think the community hasn't come up with a consensus on how to address the milder spine compression changes or the decline in bone mineral density. I'm just speaking from my program's perspective, where we do bone health surveillance, and we may differ a little bit from other centers in that we have this very proactive approach to say that if we monitor your bone health density and it's declining, if we do the annual surveillance of spine x-rays and we see little changes, we tend to start bisphosphonates at that stage, but because it's more of bone health protection, they don't have pain, they don't have loss of significant height, like moderate to severe compression, we tend to use the oral, and that is alendronate or Fosamax. And so we just published our experience from Cincinnati, because I started using Fosamax from 2005. So basically we have 15 years of experience with that. And that just got published in Neuromuscular Disorders just this past month. But you see, this is a new approach that hasn't really been kind of in consensus right now. So those that use IV zoledronate, I do use IV zoledronate with my colleagues for my patients who have moderate to severe compression, and that's usually the group that had been missed out for the initial surveillance phase. They come to me already with severe compression and in pain. Now that group, it's too late to do oral, it takes time, and that group we do IV zoledronate. Now, zoledronate is now the preferred because in pediatrics it's once every 6 months, adults is once every 12 months. It used to be pamidronate, which is once every 4 months. And I think with COVID hitting, it hit home that you want to veer away from trips to the for more infusions. So I think if your doctor is going to use IV, I think most people are now going towards every 6 months and every 3 to 4 months. And now with our older patients who's older than 18, we've got more options of subcutaneous, like, you know, denosumab. And so there are options, but I think the area of bone health hasn't really been, like, you know, kind of agreed on. It's still emerging.
A question regarding a 10-year-old boy that's been diagnosed with DMD for 4 years. He has seen endocrinology only once. How often do you recommend patients be seen by an endocrinologist at this age? He's 10.
Yeah, I think, you see, Like in my clinic, I have like, what, 300 Duchennes. I cannot afford to send 300 Duchennes to my endocrinologist clinic. So it depends on clinics. Basically, bone health should be monitored like every visit. For us, it's once every 6 to 12 months. But in terms of the monitoring of the bone density and the spine x-rays, we do that every year. So otherwise, you will know whether you're kind of getting worse, that you need to kind of jump in to be more proactive. And you do need to check your calcium intake to make sure that's optimal. That I think the general clinic should be, the dietitian would be looking into that. And your vitamin D levels. I'm so glad that I see that being done this day since about 5-6 years ago. We started that in 2005, so we do get quite a handle on, who are the kids. If you're low vitamin D level to start with, you'll always be needing supplements.
Okay.
The question on adrenal insufficiency, I'm so glad that I've not encountered any in all my like 1,000 over patients.
Okay.
Even though those that have missed doses, but that's not a good thing to do. So you are supposed to take it every day.
Okay. We have time for just a couple more questions yet. My son's 17 years old, and I was just wondering what, if any, new programs are out there to help him live longer with Duchenne. Such, she would like to find something, if possible, to keep his quality of life moving forward.
I think if at 17, you should be plugged into a neuromuscular clinic or MDA clinic, or one of the pediatric clinics. But when you pass 18 or 20, folks tend to transition to the adult centers. I think there's work going on to build the adult centers based on this concept of integrated care or multidisciplinary clinics, because now our patients are doing better and older. I think that probably I would advise that, if you contact your MDA coordinator, that really would be helpful to guide you as to which will be a clinic that can actually work together to improve the outcomes for the various system.
Okay. And does testosterone increase production of dystrophin?
No, it does build muscle mass, but dystrophin is the protein in the muscle membrane. Doesn't.
Okay. All right. Here's just a question, a person concerning the COVID situation that is going on right now. They're just curious if any of your DMD patients have been diagnosed with COVID, and if so,
No.
what are they doing?
No, so I think maybe if I just have a few seconds to talk about COVID.
Sure.
Basically, I think there are two things. You want to know what's the risk of getting COVID, and then the risk of complications. Even for the patients on steroids, the dose that we're using for my program is a daily dose, and it's like 0.75 mg per kg per day of prednisone. Now, at that dose, they're not immunosuppressed terribly. And also, we know that over the 2-3 decades of steroids, we have not encountered patients that have got more infections because of the steroids. So your risk of getting COVID is the same as everybody else. It depends on where you are. It depends on your positive testing rate that will predict how the risk. If you've got a positive testing rate like 1%, the chances of it's lower. And so I think the other one will be your public health measures that we are all familiar with. But I think the other one, where in terms of complications, we usually know that they have got a risk of cardiomyopathy, pulmonary. We usually would kind of make sure that they are not going to jump into crowds, are going to school where there's no social distancing and measures in place. And I'm not sure, but then, our patients on steroids are not on a high dose, but they don't seem, I think it may help them prevent that cytokine response, because we are using increased doses of prednisone for our gene therapy trials to try to prevent that cytokine response to react to the gene therapy. So I think our patients are good. I've not had anyone, and I was on a conference with all our colleagues that came up with that paper of COVID and DMD, and my colleagues have known of their patients as well.
All right, well, that's good. And I know we typed in our chat, we have a COVID resource page on mda.org. So I urge people to click on that page as well. Well, Dr. Wong, thank you very much. This has been very informative, and a lot of questions were answered. So thank you very much for your time.
Thank you. Have a great day.
Thank you, you too. And we are going to take a quick break and be back at 10 after to hear about clinical trials and research, so stay tuned. Remember, you can chat to other attendees today by clicking the chat icon at the bottom of your screen to all panelists and attendees and type in your comment. So thank you very much and stay tuned.